If you would like to work directly with Dr. Kole to maximize your sleep quality with a comprehensive sleep coaching program, or if you're concerned that you have sleep apnea, or simply just want a second opinion consultation, she's now available to see patients in New Jersey, New York, California, and Georgia, with more states coming soon. Please visit oak.care/sleep for a complete list of telemedicine services with transparent pricing. You deserve rapid access to quality sleep care with a physician you can trust to have your back every step of the way on your journey to better sleep.
Hi, I'm Dr. Alison Kole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. If this resonates with you, please follow me on Apple, Spotify, or your favorite podcast app. Well, welcome everyone to another episode of the Sleep is My Waking Passion podcast. I'm your host, Dr. Alison Kole, and I'm joined with me a wonderful researcher named Alexander Sweetman. He's actually he braved the time difference to spend time with me in his early morning. He is based in Australia, and he has done some really fascinating research on a not so new, but new entity is what I'm going to call it, because up until this point, having been in clinical practice for over 10 years, I'm very familiar with treating patients who have sleep apnea, and I'm also very comfortable with treating patients who have insomnia. But now we got to go and we merge the two, and it brings up some really interesting points. And it's also, I want you guys to really think about, whether or not, if you're struggling with your sleep, is it really just that you struggle with your sleep, or do you have a breathing problem? And conversely, if you do have sleep apnea and you really find that you're not really able to maintain sleep very well or get to sleep and you struggle with that, maybe this is an entity that is kind of part of your life, and maybe a different approach is called for. So without further ado, Dr. Sweetman is from the Australasian, did I say that correctly? Hopefully, Australasian Sleep Association. I basically pillaged all of your research. I was like, this is so well written. This is amazing because it's such a nice synthesis. So why I kind of, I'm calling this the COMISA, when insomnia meets sleep apnea. And I was hoping you could share with folks a little bit about like how this term came about, because it's been something that's been talked about actually for a long time, but you seemed, and your researcher colleagues seemed to be able to create a link and put it on the map, as opposed to it just being like a meh, yeah, you got kind of both of these things going on. Let's just talk about sleep apnea.
Mm-hmm. Yeah, well, first, thank you so much for inviting me, Alison, to speak on the podcast. It's wonderful to be here, and brilliant that you've turned a spotlight on the COMISA field. So we're really interested, as a pretty small and up-and-coming group of researchers and clinicians in this space, to increase recognition of the comorbidity and develop new treatments and ways of managing it. So, yeah, thank you. Some of the history. So interestingly, the comorbidity of insomnia and sleep apnea was first recognised in 1973, so a long time ago, in a publication in Science by Christian Guilleminault and colleagues. For the next 30 years or so, it had almost no research attention at all, so hardly anyone mentioned the comorbidity of these two conditions in the literature for 3 decades. And I think it was really 2 studies out of the US in 1999 by Kenneth Lickstein and 2001 by Barry Krakow that started to draw more research and clinical attention to this comorbidity. So the Kenneth Lickstein paper, they recruited a sample of people who reported insomnia symptoms. They asked them about really obvious manifestations of sleep apnea, like frequent choking, arousal, snoring, that sort of thing. And this was for an insomnia clinical trial. So they actually wanted to screen people with sleep apnea out of the clinical trial. So even after taking those people out that reported really obvious manifestations of sleep apnea, Still, in the remaining group of those with insomnia, about 30 to 40% still had sleep apnea on overnight polysomnography, so really high comorbid prevalence rates. And the
That is
inverse
crazy.
of that, it's crazy, right?
Right?
Even after trying
like you
to
try to
exclude
screen them
oneself before,
out, and yet you're still discovering that close to half of your patients, hey,
had
guess
at least
what? They still have
mild
sleep apnea.
Exactly right, yeah. So I think, like you say, that made people really start paying a little bit more attention to this comorbidity, given the prevalence rates were so much higher than they expected. Sorry. The inverse of that as well in 2001, so just after, Barry Krakauer's group recruited a sample of people with sleep apnea or sleep disordered breathing and asked them about insomnia symptoms, and 50% of that group with sleep apnea reported clinically significant insomnia symptoms. So again, a really high prevalence, but the opposite denominator. So Barry Krakauer's group started with a group of patients with sleep apnea and assessed how many had comorbid insomnia rather than the other way around. So I think it was those two papers in fairly close succession that started to drive this increase in research attention in the field. So Christian Guilleminot and colleagues back in 73, dormancy in research attention, and then two papers in close succession that started driving that increase. So after that time, quite a few prevalence studies, mostly in sleep clinic populations. And I think that's because the PSG data, or polysomnography sleep study data, are just more readily available in sleep clinic populations. So researchers didn't have to go and pay extra to undertake PSG in different populations. More prevalent studies in sleep clinic populations, a few single-arm treatment studies and pilot treatment studies to work out how do we start treating these patients with the comorbidity, and more review articles. And in 2017, my research group at the Adelaide Institute for Sleep Health at the time coined the term COMISA, and that was when I was lucky enough to start my PhD in this field. And since that time, it's been magnificent to see it gradually take off, gain more recognition around the world, and hopefully we can use this momentum to develop and implement more effective treatments for this condition. That's a nutshell of the history.
What you're doing is you're essentially saying, all right, this is a subsegment of a couple of very important populations that, in my mind, we've been really viewing as two separate populations, yet and saying, okay, well, you have this and you have this. And, or to some people, and you pointed this out very eloquently, it's almost like there's a bias when we, what am I trying to say? What I'm trying to say is, in medicine, it's very beneficial for us to create constructs, because it's how then we can keep it in our head. Everything is organized, how we approach patients. Okay, it's this condition, it has these features. The downside of that, because there's a pro and a con. So the pro is that it's very organized, it's very accessible. And if you're a very, linear thinker and you like that degree of organization, for folks that are, clinicians like myself, I certainly appreciate having that differential diagnosis, as we say in medical parlance, in your head. But the flip side is there are some inherent biases that get created as a result of, maybe over labeling or labeling in such a way where people may not creatively think. So how, you guys coined this term, and I'm just curious, you obviously were starting your PhD then. What motivated you to kind of really dig into sleep so much?
Yeah, so prior to my PhD, my background is in psychology, and I'd worked a lot with Professor Leon Lack at Flinders University, who's one of the behavioural insomnia experts worldwide, very well known in behavioural sleep medicine and circadian biology, sleep crossover. Leon is a great mentor, tutor and supervisor, so I was really passionate about the area of insomnia and also the delivery of cognitive behavioural therapy for insomnia, the most effective treatment that we have for insomnia. And then at the start of my PhD, I was also lucky enough to be co-supervised by Professor Doug McAvoy, who's one of the leading experts in sleep apnea and was the chief investigator on the SAVE trial at the time. So I think having those two giants in the field to drive my passion in the area and foster my learning and growth was really critical. And then I was also lucky enough to work with a great multidisciplinary team at Flinders and also in Queensland, so another state in Australia, on this large government-funded clinical trial looking at different treatment approaches in patients with comorbid insomnia and sleep apnea. So that's part of what really drove my passion for the field. And then since that time, it's been brilliant to connect with more people around the world, a pretty small group of people, but there's enough of us in different countries in the States and throughout Europe and Canada that are really interested in this COMISA field. So we've formed a bit of a consortium or a bit of a group and have continued to publish and conduct research in this area. So it's been wonderful to use this
and your
small but
research
up-and-coming field. Sorry, yeah.
No, what I was going to say is your research it's really been great. I mean, it's really enlightening, and I really had always come with an intrinsic, this is my bias, right? An intrinsic bias that I'm like, cognitive behavioral therapy. Okay, I know it works for insomnia, but what the heck am I going to do with my sleep apnea patient who is going to be non-compliant because they have insomnia? Like, I would stress about it. And it didn't dawn on me that cognitive behavioral therapy could be successful. You know, it just was I almost like biased myself out of even looking into that, because I was like, there's no way. Like, I'm going to sleep restrict them. There's going to be they're going to be too tired. They're not going to want to do it. I almost like talked myself out of it. And your talk, so I went to a talk, guys. I got to listen to a talk online that Alex gave. And I was like, whoa, this is really wild that this could work. And I'm not dumping sleeping pills on someone just to get them to be compliant with their CPAP. And that was really kind of what we talked about a decade ago. It was like, okay, well, there's some data that shows that Ambien is safe and also known as Zolpidem. So you could consider using something like that in the patient population. But, there's all these other issues with using medication for sleep. And when I first started practicing, I had a couple of patients who really struggled, and the Zolpidem seemed to work for them, but then I could never get them off. And I was like, what did I do? I created a monster. They're very compliant with their CPAP, but now they have to use Zolpidem all the time. Yep. And it really got me questioning that sort of approach. Definitely. Okay. So I did want to pause for a second, just because this is something I want everybody to really understand what we're talking about, where this is meant to really be understandable to everybody. So when we talk about insomnia, we are really defining what we're looking for, those patients. We're looking for people who should be patients of sleep physicians, in my humble opinion, so that we can help you with this. But anybody who has trouble sleeping chronically, meaning at least 3 months, at least 3 times a week, is what we're looking for. So there's a chronicity, there's this, this persistent difficulty sleeping. And that could mean that you have difficulty falling asleep. That could mean that you have difficulty staying asleep. So you're waking up a lot of times during the night. And I dare say that's a huge issue for a lot of sleep apnea patients. As we know, 50% will have difficulty with this. And sleep maintenance insomnia is what we call it. And that's clinically what I've seen. And that data resonates with me. And then lastly is some people end up waking up early and then they can't get back to sleep because they've sort of slept most of the night. So we call that early morning awakening. When we're talking about sleep apnea, and I'm using that term loosely, the vast majority of folks have obstructive sleep apnea. So they have relaxation of the upper airway musculature when they're going to sleep. We're all made of muscles up here. And what happens is once your airway relaxes, for some people who have obstructive sleep apnea, which is by far the most common type of sleep apnea, 10%-ish of probably the global population, it's estimated that probably 25% of folks in the United States alone have sleep apnea. What's going on is that you'll have times when you literally will stop breathing because the airway will either not allow any airflow, or the airway is so narrow, it's like you're just breathing a little bit and you're moving air up here and you're not getting air into the lungs where oxygenation happens. And if that occurs, if you have apneas where you stop breathing, or hypopneas where the airway almost completely closes off, and those events occur more than 5 times an hour, we say, there's a case of sleep apnea. And when we're talking about mild, moderate, severe, I'm talking about in the context of how we define it in 2023 in AHI. So if the number of times you stop breathing per hour is more than 5 times an hour, guess what? You have mild sleep apnea. If it's more than 15, you have moderate. If it's more than 30, you have severe. But I want you to move away from that sense that mild somehow is okay, especially if you're still having difficulty sleeping with mild sleep apnea, because that is ultimately a problem too. Because now what we're learning is that you need to have quality sleep. So how you sleep, even if you're sleeping during the night, are you actually maintaining sleep? And also quantity. So we want to maximize how long you're sleeping and make it the best quality possible. So thank you for allowing me to go in that direction. You had shared in your talk why it's so challenging sometimes to really kind of figure some of this stuff out, and how people can be skewed into thinking, oh, I'm just dealing with a sleep apnea patient versus an insomnia patient, just in terms of shared symptoms. And I also wanted you to talk a bit about how insomnia, just difficulty sleeping, can potentially make sleep apnea worse. That was a very interesting bidirectional relationship that's been figured out. So I'm going to turn it back to you.
Yeah, for sure. Yeah. And to pick up on what you were talking about before as well, that these have mainly been seen as two really separate, distinct conditions in the medical field, which I think has limited research in the COMISA space a little bit. And part of that you touched on is that there are quite different risk factors for insomnia and sleep apnea. So insomnia has historically been seen as a condition that mainly affects women and middle to older age women, associated with anxiety, perfectionistic personality traits, and so on. And sleep apnea is like totally different from that stereotypical presentation, mostly occurring in males, middle to older age still, but overweight. And a hallmark feature or risk factor for sleep apnea is probably daytime sleepiness or tiredness. So a predisposition to fall asleep during the day without necessarily trying to, which is sort of exactly the opposite of what insomnia is, right? You think sleepiness is quite different from sleeplessness, which is insomnia. So it's very different risk factors that clinicians are probably looking for. And as a side note, if I had a rare condition, I would want all of the really obvious risk factors for that rare condition. You don't want a rare condition without the obvious risk factors, because it's harder to pick up. And I think it's the same in this case. So that's probably partly the bias that you were talking about before. But now we know there's lots of different presentations of both insomnia and sleep apnea. And when we look at the data in pretty much any different setting or population, about 30 to 40% of patients with either condition have both. So one of the main take-homes there is that it's really important, if someone has insomnia, to start talking about and, if possible, assess for symptoms or the presence of sleep apnea. And then the opposite, if someone has sleep apnea, it's really easy to use some of the brief screening tools to assess for insomnia, so to pick it up when they co-occur. Your question about can insomnia make sleep apnea worse? So we wrote a paper a couple of years ago which had a lot of theoretical relationships between insomnia and sleep apnea, so bidirectional associations. One, we think their higher prevalence is an indicator that they might be bidirectionally related. So insomnia is more prevalent in those with sleep apnea compared to those without. And sleep apnea is more prevalent in those with insomnia compared to those without. So just the prevalence rates compared to general population prevalence estimates, we think they co-occur more frequently than would be expected based on those general population data. Another one is looking at treatment approaches. So if we take a sample of people with COMISA and start them on CPAP therapy, or continuous positive airway pressure, a lot of the patients with insomnia won't be able to tolerate CPAP very well. They'll still have difficulties falling asleep at the start of the night, or they'll still spend a long time awake throughout the night wearing these pressurized masks over their nose or nose and mouth. probably more likely to perceive the negative side effects of CPAP, or some people with insomnia might just view CPAP as a threat to their sleep. Think, no way am I putting that on my face when I've already got these
100.
difficulties falling asleep 3, 4, 5 times per night. So that's a common finding, but there's a caveat to that. Research has detailed a subpopulation, or a small number of people with COMISA, actually tolerate CPAP perfectly well, and it treats both their insomnia and their obstructive sleep apnea. So insomnia improves after CPAP in a small number of patients with COMISA. So that indicates that in some people, the sleep apnea might be contributing to the insomnia. We treat the sleep apnea and the insomnia remits. When they don't use treatment for the sleep apnea, the insomnia comes back. So we were really interested in the reverse of that relationship as well. And this gets to your question. This is a long way of getting to your question, sorry. But the reverse of that relationship is what happens if we treat the insomnia with cognitive behaviour therapy in patients with COMISA? What effect does that have on their sleep apnea? Does CBTI work? So does it improve their symptoms of insomnia? And then does CBTI change any subsequent manifestations of their breathing during sleep, or how bad their sleep apnea is? So one of the trials from my PhD was a randomized controlled trial in 145 people with comorbid insomnia and untreated moderate or severe sleep apnea, so an AHI of 15 or greater, like you were just saying. We randomized those participants to either a 4-session CBTI program with a psychologist or no treatment control, just to reflect what these patients commonly receive in clinical settings. And we assessed their sleep apnea severity with overnight polysomnography at baseline and then after treatment. And we looked at changes in sleep apnea severity before and after CBTI. And at both of these time points, these participants weren't receiving any treatment for their sleep apnea, so completely untreated. The CBTI group experienced a small but significant improvement in their sleep apnea severity, about a 5.5 point difference in their AHI, and I'll let you interpret the clinical significance of that, being a sleep clinician, whereas the control group experienced about a 2-point increase in their AHI, which wasn't significant. So although CBTI is not a treatment for sleep apnea, we thought it was really interesting that treating someone's insomnia actually improved someone's manifestations of sleep apnea. It didn't bring them below the clinical threshold overall, but we thought it pointed to some bidirectional relationships and the possibility that someone's insomnia symptoms might contribute to manifestations of their sleep apnea, so pointing to those bidirectional relationships.
What I found fascinating was in the discussion, which makes a lot of sense to me, though I know it's not necessarily like A plus B equals C, or it hasn't been proven, is the idea of your upper airway being musculature. And what happens when we really don't sleep well or we're chronically sleep deprived? We definitely lose some of that tone. We're less strong, we're less robust. In many ways, if you take any organ system, we're not going to do as well if we're we're lacking sleep, or the quality of sleep that we have is really crappy, which is often what happens with sleep apnea because your body's trying to compensate for the fact that you're not breathing properly at night. So it was interesting because what you postulated was that the tone probably improved because their quality of sleep improved. So they basically were just more rested. So those muscles were a little bit more primed to potentially be open. Doesn't mean that it's going to cure their sleep apnea, as you mentioned, but what a fascinating discovery. And I would dare say the one thing about cognitive behavioral therapy is that you've at least shown that. Now, it's a small randomized trial, but you've actually demonstrated it in a randomized trial. And if you look at data from like Zolpidem or like Zipiclone, which is Lunesta, they were able to say, okay, well, the sleep latency, improved so that people were able to kind of fall asleep and had a little bit more sleep, or I think their sleep efficiency improved. Forgive me. Basically, they slept better, okay? I may not be perfect, but I'll say they basically slept a bit better, but they were never able, they were looking at things like, hey, did I improve pharyngeal tone? They were looking at some other stuff to try to like kind of tease that out. And they weren't able to demonstrate, no numbers changed, at least if you base it on just an apnea-hypopnea index. So I thought that was really sort of interesting. Do you know any of the data in terms of the medications? Anything that I'm missing here? Because I know that zolpidem's generally safe and it's been tested, but some of those things are like, we gave them it for one day and they got 10 milligrams and we did not see that their sleep apnea got any worse. And that's kind of where it ends. I couldn't really find a lot of robust data about that.
Yeah, I think the early ones, the medication trials were single night, more for safety and tolerability, but there have been multi-night medication trials now. One with zolpidem that improved objective sleep efficiency to a clinically meaningful amount. And there's some emerging research at the moment looking at the new dual orexin receptor antagonists, specifically in comorbid insomnia and obstructive sleep apnea. So there's I think at Sleep, the APSS conference last year, there was an abstract presented. And there's some trials, really actively ongoing research at the moment in this space. So it will be interesting to see what comes out in the next year or 2 years in the pharmacology space around COMISA. So specifically for patients with comorbid insomnia and sleep apnea, rather than just taking clinical trials done in patients with OSA and extrapolating it to what would happen if they had COMISA, sort of thing.
And that would be interesting too, is if you could compare the people who are getting cognitive behavioral therapy and, you know, having a medication arm and kind of seeing how they compare. You'd have to try to figure out a trial where there's a sham and all this. I'll leave that. You're the researcher. I'll leave that to you. But I think it would be an interesting question to see if we knew
Okay.
if there was a difference.
I'll dream something up. Yeah.
If we could show at least, you know, how much does the pharmacotherapy really help? Because the reason I bring that up is just in general in the insomnia literature. I've reviewed this topic with a couple friends of mine, and I find it fascinating that the improvements in how much more sleep you get often for some of these medications that people are so sort of married to actually aren't really all that robust compared to even other data that you read, even on things like food or, you know, CBTI. So I don't know. I would love for there to be a pill that someone could take to help them in that case where CBTI is just not working, because we know that there are people that CBTI just doesn't work. So
yeah, there was a great meta-analysis published in Sleep in 2014 looking at placebo effects for pharmacotherapy for insomnia, and about 2/3 of the effect of sleeping pills was accounted for in the placebo group. So there are huge placebo effects in pharmacotherapy trials for insomnia, huge demand expectation placebo effects going on. Something to pay attention to. What I'm really interested in, the sort of research direction that I'm really interested in, we know that CBTI is effective for 70-80% of patients, including that percentage of patients with COMISA now, but it's really not accessible or not easily or readily accessible. In Australia, only about 1 to 2% of people with insomnia access CBTI. So a huge number of studies, hundreds of clinical trials, 30, 40 meta-analyses we're probably up to, showing that CBTI is effective across populations, and also a meta-analysis of CBTI studies in COMISA that we've published now. We need to work really hard to make CBTI much more readily accessible. So I'm interested in trying to implement CBTI across different settings in primary care, the community, and really also in sleep clinic settings, a lot of which mainly specialise in the diagnosis and management of sleep apnea alone. But now we know that CBTI works, why can't we work harder to make it more readily accessible in sleep clinics, where we know that 40-50% of those people with sleep apnea will also have insomnia symptoms?
well, I would say that Jason Ong, who I think you've quoted some of his papers in your literature that you've written, he's with Knox. Yeah.
Yep.
He's with Knox Health now. And I know he's working on essentially, Knox Health works on the platform of telemedicine, essentially sleep telemedicine. And they do have cognitive behavioral therapy there. I know he's been really involved in establishing that insomnia program. It would be really neat to see if something telemedicine like that could be implemented that people can do. And there's other apps and everything out there. There's CBTI Coach, for example, that's been out for a long time, that's free to the public and available for veterans. It was something that was talked about a lot by Jen Martin when I trained under her. So there are programs available, but it would be really interesting to see if you could partner with someone who has the particular deep interest in obstructive sleep apnea, especially if you're friends. Heck, you could implement what he's doing. I think it would be great data. I don't know how much they're doing of that, but I just wanted to throw it out there. I made that connection when I was reading your work.
Yeah, Jason's brilliant, one of the other main researchers in the COMISA space, and Jason and Megan Crawford led the Matrix trial, which was one of the other seminal recent RCTs in COMISA. I work a little bit with Jason. Stay tuned for some book chapters and other articles coming out soon.
Very, very cool. I want to finish with one more point, because I know you're going to have to run, which is essentially, why is it that people should care so much about COMISA versus just having sleep apnea or just having insomnia? We scratched the surface a bit, but can you just summarize for folks why they should maybe take that extra time to talk to their doctor about this?
Yeah, that's a good question. We should have started there, shouldn't we? We got carried away with a lot of research and clinical trials and whatnot, but doesn't matter. Why does it matter? So by definition, people with COMISA not only have difficulties falling asleep or staying asleep throughout the night, but then when they are asleep, they're experiencing these repetitive episodes of airway narrowing and collapse. And it's sort of unsurprising that when you combine those two things together, some of the consequences can start to be worse. So people with COMISA generally have worse subjective and objectively measured sleep parameters or indices of how well they're sleeping or their quality of sleep compared to people with neither condition, and often compared to people with insomnia alone or sleep apnea alone. So we think the sleep is worse when we combine them together. Yep.
I just wanted to pause to highlight what he's basically saying is how you feel is worse. And when we look at all the nerd stuff that we need to look at, we also can tell that you're not doing as well if you have COMISA versus just having sleep apnea or just having insomnia. Okay, unpause.
Exactly. No, yeah. Thank you for that clarification. Yep. So the sleep is generally worse in people with COMISA. Unsurprisingly, that can flow on to how people feel and function during the day as well. So levels of fatigue, lethargy, concentration, and mood can sometimes be worse in people with COMISA compared to those with either condition alone. And then when we look at other clinical disorders like mental health conditions and other physical conditions, there's also some literature saying that rates of depression, anxiety can be higher in those with COMISA, and also a couple of studies looking at cardiovascular disease and markers of cardiovascular health, which can also be elevated in those with COMISA compared to those without, or those with either condition alone. So a few different markers indicating that the consequences might be worse in people with COMISA compared to those without COMISA, which is something to pay attention to. But thankfully, we do have effective treatments, which we were talking about, and a lot of our work is to try and start implementing better access to those effective treatments.
I thought of one more question before I let you go, because in your trials, you guys really did the cognitive behavioral therapy as the first step. And that is what you highlighted in one of your more recent papers, was that the general school of thought now is start with the cognitive behavioral therapy. My question to you, because obviously you do a lot of research in this and I'm coming from the clinical side, is there a cutoff by which you should humbly start with CPAP versus opposed to cognitive behavioral therapy? I mean, if I had, I have no proof of this. And believe me, I would love to hear any more data if you have it. But my general gestalt from having treated folks for over a decade is that, particularly if someone really is bad, like they're having pretty severe sleep apnea, they're stopping breathing a lot of times, and they're also saying, I can't maintain sleep. Particularly if they're very sleepy in the morning, I've noticed. So that phenotype for me, meaning the type of patient, that they tend to be really tired, they tend to have really fragmented sleep, and they tend to have very bad sleep apnea. When I put them on CPAP, most of those patients I've at least seen, the CPAP seems to fix it. So just in terms of, the ethical dilemma with the clinician, it's like, okay, well, if you have this combination, has it been elucidated? Like, is it just an opinion that you do the cognitive behavioral therapy first? Because I think I would have issues with, the way I counsel folks basically is I'm saying, okay, well, I can't tell you that this is going to fix the insomnia, but I do tend to push the sleep apnea treatment depending on my clinical assessment about which is more problematic for the patient. So I'm just trying to tease out like the practicalities of what should be approached first, and then the ethics of saying cognitive behavioral therapy before I treat sleep apnea. So kind of a complicated question, but wanted to get your opinion.
No, you're totally right. So one of our main studies was a randomized control trial to find out if cognitive behavioral therapy first worked. So did it improve insomnia? And also, did it improve rates of CPAP acceptance and adherence? And compared to those that didn't receive CBTI, those that did receive CBTI first, they had much better initial acceptance of CPAP and used CPAP therapy for about 1 hour more per night over the next 6 months. So as a whole group, it appears that CBTI before CPAP was the treatment of choice in that study. That hasn't been replicated across all studies, though. So there's a couple of RCTs asking really similar questions, and there's mixed results so far. But I think you're exactly right. So are there patients who are more suitable for CPAP alone, and see if that has any impact on reducing their insomnia? Absolutely. I think it should come down to first patient preference. Like some patients will have an immediate preference and a chief complaint of sleep apnea, and their partner hears them choking and waking up during the night and snoring, and they have daytime sleepiness and so on. The next, I think you've highlighted already, sleepiness and risk of sleepiness-related accidents. A lot of clinician discretion is appropriate at this point to work out whether CPAP should be expedited in some people with COMISA. So I guess what I'm trying to say, overall, in the whole COMISA population, it looks like CBTI before CPAP is the most appropriate sequence, but absolutely there's a subsample who you would expedite CPAP therapy for lots of different reasons and based on your clinical discretion. Yeah.
Well, Alex, is it okay if I call you Alex? I've been calling you that for the whole episode. I never asked permission.
Yeah, absolutely. No.
I just wanted to thank you again for your time. You really you're so well versed in this, and it's been a pleasure learning from you. I hope you guys continue the good fight of that, hardcore research, making the folks on the back end like me smarter. And, to anybody out there who thinks that, hey, I'm not sleeping well, I would encourage you to really think about whether or not there's something else going on. Oh, just poo-pooing it and saying, well, I'm stressed about this or that. Maybe there's something else going on. And it's much harder when you live alone, because you may not have anybody telling you like, hey, you're snoring, or there's something funky going on with your breathing. But take it seriously, because it really can negatively impact your quality of life just in the present moment, but also may have a lot of the downstream health effects that the goal here is to try to prevent, because we figure it out sooner rather than later. Again, thank you, Alex, so much for your time, and I hope you have a wonderful morning.
Thank you. Yes, thank you again.
Hello to all my fellow sleep biohackers out there. I have a call to action for you. If you are enjoying this podcast, if you feel that you are growing, you're more knowledgeable, you're feeling empowered about your sleep, that is the purpose. So please take the time to like and review the podcast, share it amongst your friends and family. Please follow me. If you'd like to follow me on Instagram or Facebook, I am there as well. My handle on Instagram and TikTok is AskTheSleepMD. And you can also go to my website, AskTheSleepMD.com, for more information about each of these episodes. We will be sharing with you cited articles that you can actually refer to and read yourself if you like, and lots of juicy tidbits about how to sleep better. Thank you. This podcast would not be possible without the support of Mr. Joey Salvia, who is my producer, and Adrian Paterath, my creative director. Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.